We feel privileged to have you, Dr. Anurag, today for this session. We are also joined with us today is Dr. Mahesh Satija. He's also a professor at the Department of Community Medicine at the Addis Medical College and Hospital, also equally renowned researcher in the field, several publications, several research projects. He is also a member of various scientific associations, including IAPSM, IPHA, BPNI, and I can name quite a lot of them. He's a fellow of International Medical Sciences Academy, very well organized, lots of thinking behind his research projects. We are very happy to have you. On these webinars, Dr. Rakesh Garg. He, although is a medical doctor and acts as an executive medical officer for RAIN Foundation, also brings with him a lot of technology knowledge and helps us build products which are equally sound on both technology as well as clinical aspects of the field. From all these three experts today, we will hear about why it is so important to think about maternal health, what are the current challenges that we are facing globally in India, and also some of the disparities that we are seeing with these projects, with these problems when it comes to maternal health, child health, how they are connected with some of the issues that we see in our healthcare system. And then what are some of the things that they have been doing at their level through research projects, through regular practice, and try to figure out how also technology can help. So that is the ambit and that is the focus of today's webinar. And so I'm going to actually play a video for you that will showcase some of the thoughts that RAIN Foundation is putting behind these projects. So if we can have the video, please. There seems to be some technical issues with playing the video. Uma, can we check again? Otherwise, we can skip and then play it later on.
Just 1 minute.
No problem.
अच्छा उसे पता है मैं मारूंगी नहीं
उसको ये पता है कि तुम मारेगी
हाँ दीदी अब अपना
कद्दू ले लिया
जी मेरे को लो
ये कद्दू थोड़ा तो
Okay, excellent. So this video was to just showcase some of these thoughts that we will present today. What are the current challenges that we face with maternal health, with neonatal health, in globally as well as in India, and some of the thoughts that we are putting behind these problems when it comes to RAIN Foundation. I'm going to start with the webinar now, and I'm going to first start, of course, with our esteemed researcher, expert, Dr. Anurag. Dr. Anurag, from your experience, from what you have seen in the practice, what are some of the current global challenges about maternal and infant health, and also some thoughts on the Indian challenges as well?
Hello, everyone, and I feel so privileged to be here on this platform and to share my thoughts about maternal and child health. Um, you see, maternal and child health is very important, and this is something that we have to look into it and we have to work for it. And next slide, please. Why we think that mother and child health is important? Because the child health is closely related to the mother's health. And during pregnancy, if we are looking after the mother and giving proper care to the mother, we ensure that the baby is going to be healthy. There are not going to be any problems with the mother and child. And of course, they are the future. I mean, with the healthy mother, the future is going to be healthy. Next slide, please. Okay, so if we look at the spectrum of health, we are talking about the mother's health, mother and child health. We find that there are two extremes in this spectrum. One is the best of health or the positive health, and the other extreme is death. In between, there are various fluctuations that goes on. Sometimes the mother is sick, and sometimes she is fine. And if we want to look at the health of the mother, we obviously we would look for the other extreme, that is the death. That is one indicator which tells about the status of the maternal health in a particular region or a country or globally. So we talk about the indicator for mother's health is the maternal mortality. We call it maternal mortality rate. Next slide. Okay, so this map shows the status of maternal mortality all over the world, and you find this that most of the countries they are showing very low maternal mortality, that is less than 100 maternal death per lakh live births. But in India, this is somewhere between 100 to 299, and some of the countries it is showing extremely high maternal mortality. So there's a lot of variation all over the world as far as the maternal health is concerned. Next slide, please. Now, pregnancy, as you all know, that right from the beginning, there is plenty of time that we can deal with some of the complications and we can avoid those complications. And the common complications or the common problems we find during pregnancy, or we call it high risk pregnancy, is the most common is anemia. That is, the hemoglobin levels are less, and physiologically during pregnancy the hemoglobin levels tend to fall. And in India, this is the most common problem, and this is the most common reason behind maternal mortality. More than 80% of mothers, they are suffering from anemia. So if we find early in the pregnancy that the mother is anemic, we can very well give iron supplementation to the mother and avoid the complications. The other high risk pregnancies are elderly primary, when the woman is becoming pregnant for the first time at a higher age, or when the height is less than 140 centimeter, or even when the weight is less than 45 kg, and when there is a history of threatened abortion or a history of antepartum hemorrhage, that is the hemorrhage or the bleeding during pregnancy, or very common these days multiple pregnancies or twin pregnancy, or there is a history of previous stillbirth, or the baby died in the uterus, or the female is has given birth multiple times and is in higher age category, or the pregnancy is prolonged. This is after 40 weeks of pregnancy, or there is a history of previous cesarean section, or the pregnancy is associated with medical disorders, and so many medical disorders are very common these days, like hypertension, diabetes, hypothyroidism, and there are other medical disorders. Then there is a history of consecutive spontaneous abortions, and if the female has taken treatment for infertility. So these are some of the conditions we can very well anticipate, and we can avert the complications by identifying these as high risk pregnancy. Now, if we look at the causes of maternal mortality, the most common cause is hemorrhage. Hemorrhage is bleeding. So this bleeding could be even during pregnancy, we call it antepartum hemorrhage, or this could be during the delivery, or after that we call it postpartum hemorrhage. And the most common reason for postpartum hemorrhage is anemia again. So you see, all these conditions are interconnected to each other. Then there could be even sepsis or the infection, because of so many medical reasons behind that. Then there could be other conditions like which get aggravated while the female is pregnant, like hypertension or diabetes. So these are the common problems which are leading to high maternal mortality, and you can see that all of these are preventable. So that is why previous slides, you could see that maternal mortality is more than 100 in so many countries. So, I mean, this is something we can work upon. Next slide, please. And when we look into the causes of infant mortality or the the neonatal mortality in India or some otherwise also, we find that the most common cause of the early death of a newborn is prematurity, when the baby is born before the time or before 37 weeks of pregnancy, or the baby is born with a very tiny or very low birth weight, and the ideal birth weight should be 2.5 kg and more. But if it is less than that, then the baby fails to survive, or when the baby is premature. So again, this is connected to the mother health. So if the mother's health is poor or the nutrition is poor, then there is every possibility that baby will be born premature or a low birth weight. Similarly, if the baby is suffering from any congenital anomaly or some infection is there, these are common causes. And when we look at the spectrum of infancy, we find that infancy is from the birth till 1 year of age. So we find that most of the deaths, they are occurring in early 28 days of the life, and in these 28 days, the first 24 hours followed by 48 hours and followed by 7 days are most crucial when most of the deaths are occurring. So you see, the common reasons for these early deaths is prematurity or congenital anomaly. But as the baby survives for few days, then the chances of getting infection increases. So the infectious diseases like diarrheal diseases or pneumonia or other problems, they come into action. And of course, next slide, please. Now, as I told you that when we can start this prevention program. So it is not that, please, previous slide, please. Care. So if we look at this continuum of care, we see that it is not that we have to start the preventive care when the female is getting pregnant. We can start it early also, so that the problems like malnutrition can be solved before the female is becoming pregnant. So if we ideally, we should start it from 15 years of age, and once the girl is entering the reproductive phase of life, and this can go on till the child birth and till the child is becoming 1 year or 5 years of age. So this is how we can cover the mother and child over the vulnerable period, and we can provide the care to them and prevent the deaths. Next slide, please. Now, how we can do that? I mean, there are areas of intervention during pregnancy, and as I told you that we get I mean, almost 7 to 8 months when we can provide care to the mother, and we can look at various parameters whether the pregnancy is going on normal or there is some problem with it. So what we can do is we can do a lot of a battery of lab tests, like we can look for the hemoglobin, that is to look for anemia. So if the hemoglobin level is less than 11 milligram, that means there is anemia. And we ensure that the female is coming for antenatal checkups regularly to the clinic, and then we are doing these tests like hemoglobin estimation, or look for the blood sugar levels, or whether the urine examination is normal, or there is appearance of sugar or protein in the urine. So all these tests, they let us know whether the pregnancy is going on normal, or there is some problem. We can also look for various infections like HIV and sexually transmitted diseases by simple test, and we can intervene. Similarly, the blood pressure level, it is very important to monitor the blood pressure during pregnancy, because this is one parameter which is going to increase during pregnancy physiologically also. So during every visit, the blood pressure is measured, and it is monitored over a period of time. And induced hypertension is very common during pregnancy. Then the weight is also going to increase during pregnancy, and the ideal weight gain should be between 10 to 12 kgs. So therefore, with increase, when we are monitoring the weight, we ensure that the baby is growing normally in the uterus and everything is going on fine. Similarly, we can also do the fetal growth monitoring by ultrasound and otherwise also. And these are the common things we are doing during pregnancy to anticipate any complication. Next slide, please. Now, this is something we are providing longitudinally. This care is being provided to the female longitudinally during pregnancy, but emergency can happen anytime. And when we analyze the emergency conditions, we find that the death happens due to three delays. The first delay is deciding to seek appropriate medical help for an obstetric emergency, and this usually happen in far-flung areas where the people are not too aware about these problems which are happening during pregnancy, and they delay the deciding about seeking the appropriate medical help, and the necessary time is lost in that. And if they decide about seeking an appropriate medical help, they fail to get to reach the facility on time, medical facility on time. So this is again an emergency, and the necessary time is lost. And once they reach the facility, they do not get the adequate care. So these are three important delays that is need to be looked into once there is an emergency. So therefore, it should be ensured that there is an availability of transport to transport the female who is in emergency to so that she reaches the health facility in time. Then adequate facilities should be available at the health center to deal with that emergency, like whether the cesarean section is to be done or blood transfusion is to be given. So there are so many things to be done. And on top of that, with these facilities, the availability of specialists, the obstetrician, the anesthetist, the pediatrician, all these should be available at the health facility. Next slide, please. So, similarly for child health, again, for preventing the morbidity and mortality during infancy, what we can do is that we can do the regular growth monitoring, whether the child is gaining weight as per normal standards, or the nutrition is fine, the child is being breastfed exclusively during first 6 months, or there is some problem with it. Then providing vaccination to the child in time is also very important, and it is also important for the mother to look for the various danger signs when she can very well anticipate that some problem is going on with the baby. Next slide, please. Now, as I told you that in far-flung areas where there is no doctor and the health facility is also far off, now who is the one who is helping these people? So we have community healthcare workers over there. They are part of that community, and they actually facilitate in reaching out to those people and taking them to the health facility. So they act as a bridge between the hospital, the doctor, and the beneficiary who's the pregnant female or a baby. And another importance of community health workers is they are in regular contact with these beneficiaries. They are giving them advice regarding when the immunization should be done, they are supposed to visit the health facility for that. They are supposed to go for institutional delivery or hospital delivery. So this is the role of healthcare workers, and they increase the acceptability of these services amongst the people. So since they are part of that community, so they are actually convincing them to use the hospital services, and that's how the mortality and morbidity can be prevented. Next slide, please. Now, what are the various possibilities where we can work together to reduce the maternal and child health? So, I mean, this is a very good idea that with the data is available in real time for all the stakeholders like doctor and the workers, and this qualified blood pressure monitoring, weight monitoring, hemoglobin monitoring, and they can see the deviation from the normal range, and some intervention can be done. So this is just a possibility that with the use of AI, the automatic messages can be sent to the people that the immunization is due or the antenatal care visit is due, and thus motivating them to go for these services. So we can always give health education also with the AI. So these are the possibilities with it. So that's all with the uh, challenges of maternal and child health. Thank you.
I think that was a fantastic and very comprehensive overview, Dr. Anurag. Thanks a lot for giving that wide range of challenges, but also some of the things that we can already think about when it comes to how they can be fixed, what has already been done. And we will come back to some of these pieces a little later on. But let me also ask Dr. Mahesh at this point of time, has been his experience when he has worked at the field level in India, and especially would like to ask him about if he has seen any differences between when he sees urban populations versus rural populations, and what are the challenges associated with that. So Dr. Mahesh.
Yeah, good evening, everyone. So, Dr. Rag has beautifully mentioned the global challenges. In ma'am also told that uh, the maternal mortality and the infant mortality. So these are the various challenges which is common in India also. So if you compare rural India with urban India, so there was a 1 million death study that was done way long back, I think in the year 2013 and 14, and in which various causes of deaths were also elaborated. Although because in India we lack the exact causes of death, but that study mentioned that in the poorer country, or you can say in the rural area, so the maternal mortality burden was much higher as compared to the urban. So even if you compare in the richer part also, place of residence, so there also, so the rural maternal burden was higher as compared to the urban burden. So there is a lot of difference when you compare rural India as well as the urban India. So we'll see why that difference comes out. The next slide, please. So Dr. Rag has already mentioned the various causes of maternal health or maternal death, which was there in if you see the global challenge. So I will just depict some of the you can say figures or the data, the things which ma'am has already mentioned, like what is the status if you compare in the rural as well as in urban area. So like all of us know that during antenatal time, so there are 3 or 4 visits required so that we have the favorable outcome, that is the normal birth at the time of delivery. So if you see the antenatal checkup during the first 3 months of the pregnancy, so over and all, if you see, it is much higher in you can say in urban India as compared to the rural India. So rural India, because of you can say lack of infrastructure or the lack of availability of doctor or the staff, so this antenatal checkup during the first trimester, that is little lesser as compared to the urban area. So like I was telling you that under Indian public health standards, that is quality health standard laid down by Health Ministry of India, so there are at least 4 antenatal care visits which will be required so that no maternal death take place, so that we should not lose any pregnant female, because which is a physiological phenomenon. Okay, so you can see here, if you compare this 4 antenatal care visits, so it comes down from 67.9 to 54. So only half of the rural females, they are availing the 4 antenatal care visits, which are required, which ma'am has already elaborated, in which we have to have hemoglobin estimation, we have to have blood pressure estimation, we need to have weight examination, we need to give pregnant female the tetanus immunization, and we'll see here the how many pregnant females are protected against the neonatal tetanus. So this we are like having almost equal between urban and rural, because the tetanus awareness is there definitely, and we are giving this tetanus immunization. Again, it is not 100%. It should be 100% in our country, so that every female is protected against neonatal tetanus. And then, of course, ma'am also told anemia is one of the major cause of maternal death. Similarly, in India also, anemia. We see, you can say, severely anemic pregnant female coming in the rural area. So that is less than 7 gram percent. About 10 to 13% of our pregnant female in India, especially rural India, they are severely anemic. So, and if you consider it as less than 11 gram percent as per the reproductive and child health program, which is there in India, so again, it is 50% of the pregnant females are anemic in our country. So if you take it as 11 gram, and if it is you take it as you can say 10 gram, so it comes out to be higher. And also the iron and folic acid tablets, which we are giving to a pregnant female for 100 days. And also now there is a little change in the guidelines. We are have to give it for the 180 days. So again, that prevalence is very, very low. So I think now we can correlate that because of this anemia is there, and that anemia is causing the high proportion of maternal deaths in India, and it is very, very higher in rural India as compared to the so what we can do under maternal health. So we have to reach every mother. So email, so to provide them the services which are available at free of cost, so that they have the accessibility to these type of services. And continuum of care, ma'am has beautifully mentioned already, that then of course antenatal care. So antenatal care, that is what I think which we need to focus on. And for that, various schemes have been initiated by government of India, in which we have to have to provide these pregnant female at least these 3 to 4 antenatal care visits, and then the adequate educating them on adequate nutrition, and the plan has to be made here. That is the delivery plan, where the delivery will be taking place. So like in India, if you say, if I will tell you the Punjab region, which is there, so maternal mortality, you can compare with the national average also. So few years back, so half of the deliveries were at home only. So now with the introduction mentioned on the 3 delays, or like possible areas on which we can work upon, and we which government of India, or which even the sustainable development goals which have fixed for India, like 70 per lakh live births. So still it is beyond reachable. Next slide, please. Yeah, these programs what I was talking about, that is initiated by government of India. So that is Janani Suraksha Yojana. Now we have talked about maternal health issues in rural India and urban India. Similarly, we are also facing challenges about the infant health here, and infant mortality is very, very higher as in rural India as compared to urban area. Although things are improving, but still, and like ma'am has also mentioned that if you see that 1 year of life birth of you can say the infant, so that first month is very crucial, the neonatal mortality which we call. And out of these 30 days of life or 28 days of life, first 7 days is very crucial, in which we call early neonatal period. So that these programs have been initiated to reduce that burden, that neonatal deaths or early neonatal first 7 days of life, in which we are losing many infants in our country, and especially in rural area, where essential newborn care when the child is born, that is not available. And it has been seen that around 45 to 46% of these deaths happen during the first hour of delivery or the live birth. Okay, so Janni Suraksha Yojana, which is very successful, in which the beneficiaries are given some incentives, and we have appointed Asha worker here, which is from the community, and so that to overcome any social or cultural barriers. So with the help of these incentives, which are provided to the Asha worker also, and also to the pregnant female. So the Asha worker is being given performance-based incentives. She will prepare the birth action plan, and then she will take the pregnant female to the institution for delivery, so that we can prevent all these maternal deaths in rural area as well as in a urban area. So and also the infant. So essential newborn care is being provided, where the Asha worker will take the pregnant female for the delivery. So that early neonatal deaths will be avoided during that time. So Janni Shishu Suraksha Karyakram is again another milestone in which the first 30 days of life of mother as well as child death is taken care of by government of India. So it is provided free of cost, the treatment as well as the drugs and the transport. Similarly, the Pradhan Mantri Surakshit Matritva Abhiyan, that was initiated by our Prime Minister. So in which again it is the focus is on maternal and child health. And there was one quality you can say improvement initiative, in which labor rooms are being initiated, and quality maternal care they are going to give. And of course, slowly they are developing it, but definitely it's again a good concept whenever we talk about the maternal and child health. Now, these village health and nutrition days are very important. So every month in the village, the health and nutrition day is celebrated, in which our workers, they come at one place, and then Asha worker and Anganwadi workers are there. They are from the same community of that village only. So they will bring these mothers as well as the children to that particular place, in which all these antenatal care and the immunization and everything will be provided, and the nutrition education will also be provided to them. So next slide, please. Yeah, this I was talking about Janni Suraksha Yojana, and you can see here we have low performing state and high performing state. Let me tell you about some low performing state, in which the indicators are very bad, where the maternal deaths are more in number, infant deaths are more in number. And high performing states, like we have southern states, we have Maharashtra, we have Punjab. So and these are high performing states, and the states like Bihar, Rajasthan, Uttar Pradesh, Chhattisgarh. So these are low performing states where the lot of maternal deaths or infant deaths happen. So government of India, they give in rural area 1400 rupees for that purpose. So some incentive, and then in urban area it is 1000 rupees. So and similarly in high performing state it is 700 and 600. So this, and of course, you cannot tell each and every person or any pregnant female to go to institution. There will be some barriers also. So even if she is being delivered at home, so by healthcare worker, so there also we will be providing them with 500 rupees to each and every one. So this is something, this program, because of this Janani Suraksha Yojana, we Government of India have achieved uh, some improvement in maternal and infant health, and we are able to reduce maternal mortality in India as well as the newborn deaths. And Asha worker is major component, and which ma'am also talked, and that we can involve these persons at ground level, our A&M healthcare workers, Asha workers, and maybe the technology part ma'am has told that we can introduce that technology part, and everybody is having nowadays using mobiles and everything, and we can use that technology in reaching out to the population. So they are being given around 600 rupees for ANC के लिए जो है for antenatal it's 300 rupees, and 300 rupees for taking pregnant female to the institution. So this is like Janani Suraksha Yojana, where it is working in India at the rural level. Next slide, please. These are the thrust areas under our child health program. If we discuss something about that, we should focus on neonatal and child health. So after the delivery, and like I told you, first 28 days are very, very crucial, and out of that, first 7 days are very crucial. So of course, we should focus here on some breastfeeding component, and for 6 months only and only mother's feed is beneficial for the child. So like that, this education has to be given to the pregnant female, like after delivery, the mother's feed is very, very important. So, and then of course, nutrition, we have our Anganwadi workers at rural and urban level, so which are functioning and which are giving supplementation, nutrition supplementation. Diet is being given at these centers, and also the nutrition education and management of common childhood illnesses. Ma'am has mentioned that the causes of infant mortality. So it's almost similar in India also. So prematurity, like if the child is born before the extra time of the delivery, or and then of course the other common cause of death is common infection, in which the child is suffering from any diarrheal diseases or acute respiratory infections or pneumonia. So like that. So we have to manage these at the grassroots level. So we are providing with our workers with the some of the medicines, and the OPDs is also being run there. Immunization, and I think immunization is where we are progressing, but maybe we are still away from reaching 100% immunization coverage, at least for our first year, or you can say children which are infants. Okay. So that during 1 year of age, so lot of vaccines has to be given, starting from BCG against tuberculosis, and then we have polio vaccine. Although we have eradicated polio from India, but still because it's there in our neighboring country, so we need to focus on these polio vaccines also. Measles vaccine is something another which we have to focus, because it will prevent again these common childhood illnesses which I have mentioned here. So immunization, I think again here, some technology can help us reaching to the other people which have been lacking, and maybe some alerts from the app that can also help us in this immunization, this one having successful immunization for under 1 year children. Next slide, please. Yeah. So like I told you, so we have the way forward here. Ma'am has also mentioned that we have almost now control or almost reduce the maternal and child health burden, and we are reaching to our goals, like nearer to goals which are there, but still we have to focus, or we have to find out some other ways to reach the missing link there, and where we have not been able to reach. So I think information system for maternal and child health can help us in reaching that like way forward, where we have not reached. Or for example, tracking of pregnant women and children, the mother tracking program, MCTS, which that is known as in India. So which I think Government of India has already started it, but I'm not sure how much successful it is going on, but we have to focus on it. And there is, I think, there are many apps also working. Like we have ANM online, our auxiliary nurse midwife online, and also some Kilkari app in which some 72 messages are being delivered to the pregnant female on pregnancy issues. So some of the example are there, but I think we need more of such technology or the information system to reduce the burden of maternal and child health in India. So that's from my side. Thank you. Thank you.
That's fantastic. And once again, a very comprehensive overview. It was really surprising to see some of the differences between the rural and urban sectors. And there is so much work to be done, especially even if we know those kinds of interventions that exist, they are not being picked up at the ground level due to so many issues. So really, really a very informative and practical presentation, Dr. Mahesh. Thanks a lot for that overview. And so this is also a good segue to talk about what RAIN Foundation is thinking about doing. What are some of the approaches that we're taking on some of these specific items that Dr. Anurag and Dr. Mahesh mentioned about use of technology. And so we have already started developing pilots and projects which would help in this area. And who better to talk about that than Dr. Rakesh, who is our executive medical officer. So I will invite Dr. Rakesh to give an overview of what we are doing in this field.
Thanks, Santosh, and thanks to Dr. Anurag and Dr. Mahesh for providing us very useful information about maternal health care. As mentioned by Dr. Anurag and Dr. Mahesh, maternal mortality and infant mortality rate are the key indicator of the health state of any country. Countries all over the world are like working very hard to improve these stats. Like so far, we have achieved good success in this aspect, but still a lot of work need to be done, especially if we see the disparity in the rural and urban stats, as mentioned by Dr. Anurag. Like we say, like rural stats are very worse as compared to the urban stats. If we summarize the challenges we discussed so far, like as mentioned by Dr. Anurag and Dr. Mahesh, major challenge in healthcare delivery, especially in the developing countries, are lack of resource. Like expert people, expert doctors are not available in the remote area and rural area, basically. And second is a lack of awareness. Like most of the time, rural people are not aware what kind of facilities are available in the nearest healthcare center of government setup or private setup. And third is a compliance issue. Like discussed by Dr. Mahesh, that we need at least minimum 3 to 4 antenatal visits. And if we see that, like we compare the data of antenatal visit, usually ASHA workers register the pregnancy in the first visit. Like there is almost 95% registration of the pregnancy during the first visit. But if we say later on, second visit, third visit, and fourth visit, the percentage reduced drastically, basically. Like ASHA worker help in first visit, but later on they are not like as much aware about the later. So we can try to reduce all these basically hurdle challenges in the healthcare delivery by using technology. In the like after COVID-19, technological adoption has increased because of the regulatory approvals. Medicine care or consultation remotely. Earlier, this was not allowed, basically. Technological driven healthcare in the remote and rural area. For example, it's known fact that pregnancy outcome are not good, basically. Like if we care is because of non-availability of the nearby hospital. So this gap can be reduced if healthcare workers like ASHA are empowered with the technology, and real-time alert system can be delivered. Like suppose ASHA worker registered a pregnancy in their application. So if there is next visit due for the pregnant woman, the ASHA worker as well as the mother also get a notification that your next visit is due on this date. Women are not aware that they need to visit the hospital. So if women or family member of the pregnant woman get alert that you need to visit near hospital on this date, they may call ASHA worker or other healthcare worker that they can assist, and this can increase the company a lot, like for all the antenatal visits. Second thing, like we were discussing earlier, was that high risk pregnancies. High risk pregnancies usually lead to a lot of like death because of no detection of the high risk in early stage. If we see that usually high risk pregnancies are diagnosed in the second trimester, and sometimes it's already very delayed. So prevention of the causating factor is not possible when it's already have happened. And we have studied many studies that which trimester basically. Even some studies say that we can detect the high risk pregnancies even before the pregnancy. So if we can detect complication induced by the high risk pregnancies and avoid all kind of maternal death and infantile death basically. The few risk factors, these kind of parameters are not monitored by the pregnant woman because of lack of awareness that these are very important, vital for them. So if we can create awareness and provide instrument to like say weighing scale and simple VP patterns. If we say VP patterns is very cheap these days, but still most of the Indian families do not have VP patterns at their home, especially in the rural area. So if we can create awareness, then they can self-monitor their VP and the weight at home itself, and that can itself lead to a lot of like improvement in the basically health state of the pregnant woman. Few risk factor like anemia. We were discussing about anemia earlier. That stats say that almost 50% women are anemic. And during my like tenure as a medical officer in the rural area, whenever some woman came in our hospital, whether as a pregnant woman or some routine investigation or routine checkup or some other disease, if we say that you should get checked for the anemia, simple uh, finger prick is required to diagnose a anemia basically. That finger prick does not need lot of blood or other complication. Even then, females are not, women or other people are not like ready to get even single prick. Almost 33 to 40% women are not ready to take the prick. So we thought that we should develop some kind of solution so that we do not need any kind of prick itself. So their solution should be non-invasive also. So we build a model invasive procedure like finger prick or anything else. And simply the simple procedure is very simple. First, patient need to take the image of their lower eyelid conjunctiva and send on WhatsApp. As we can see, WhatsApp penetration is very huge in society. So they can simply use the WhatsApp and take the picture of the conjunctiva and send to specific number. And that number will tell us whether the person is having anemia or not. And if simple, this kind of simple application can tell that a patient is anemic or not, this can reduce the burden of anemia in society a lot, basically. Like Dr. Mesh was telling that at least we need 180 days of folic acid and iron supplementation. But if female are not aware that they are anemic or not, they are usually not complying. But if they are aware that they are anemic, the compliance of taking this folic acid and iron can be increased very much, basically. And second thing we were discussing was that like awareness, like there are many kind of program running in the India, especially for maternal healthcare and infant healthcare. But people are not aware of those programs many times. So WhatsApp-based chatbot can provide information about all these programs. Like any person can send message on WhatsApp, and then WhatsApp can give information like what kind of health facility or program or what kind of incentive you can get for your delivery or antenatal visit or postnatal visit. Suppose Indian government is providing facility is not available in the government setup. They even sponsor the ultrasound cost if they have to done it from the private sector. But many times females are not aware of those facilities. So we can deliver that kind of information using the WhatsApp chat also. And other information we can deliver by WhatsApp chat is that, so suppose some pregnant women want to know like complications about the pregnancy, or what kind of diet or nutrition they should take, like which kind of diet is having higher amount of folic acid or iron, or what kind of diet having proper basically what protein intake. So we can deliver all kind of this information on WhatsApp chat itself basically, and that can improve the not only the health stat of the woman, but also uh, and this kind of information can be delivered using the local language. Suppose someone do not know the English and they cannot type English, but they can type Hindi or some regional language, suppose Punjabi or Tamil, Telugu. They can send message using that local language, and this chat can reply in same language they are aware of. And second use of this kind of facility is that suppose someone do not want to type anything, or suppose someone is specially able, like blind people, they can even send an audio message. They can simply speech and talk to the bot, and bot can reply to their speech-based questions. So this kind of facilities can reduce the burden on healthcare facilities. Like they do not need to visit for small queries to nearest center. Many kind of information can be delivered by the bot itself, basically. And other things like monitoring weight. Suppose we were talking about that we should monitor the BP, we should monitor the weight, or we should monitor the calorie intake of the woman. This kind of monitoring is very challenging if we do not have some kind of proper tracking system. So at RAIN Foundation, we developed a RAIN Health Guru application where anyone can track their vitals like weight, pulse, BP, and other information regularly. And also they can track the calorie intake. And these kind of stats can be visualized, like we can have an overall summary, like what is happening in last few months, what kind of vitals are improving or what kind of vital are deteriorating. So we can get a complete summary of this information. And not only we can see that information in the application itself, we can share that information with any other healthcare provider like doctor or hospital. With single click, we can share all this information with the healthcare facilities. And like Dr. Anurag was talking about longitudinal healthcare monitoring and emergency healthcare. What I have observed during my tenure as a medical officer, I see that many times during the emergency, people do not have availability of some emergency contact number. They usually get panic when they need to call reports like ultrasound report, blood reports, so that we can share all this information on demand. Like if even if we forget to bring the room, we can simply open our application and share this information with the hospital immediately. And are basically like we want to have some kind of holistic approach in basically mother and infant tracking, like immunization tracking. We can send a message to the mother that your child vaccination are due on this date, basically. Thanks, everyone.
Excellent. That was a very good, albeit a little, fast kind of a review of what we are trying to do. This topic is actually quite, deep, and there are so many things. Even if we just talk about one of the high risk factors that Dr. Anurag was trying to present, or Dr. Mahesh talking about the urban-rural aspect, or Dr. Rakesh, as was talking about the various things that we are trying to do at RAIN. We can spend hours and hours talking about it, but I know that we are coming to an end of today's session. I actually have received one audience question, which is for Dr. Anurag, and we can just take maybe 1 minute to answer that, because we're already just 2 minutes away from the end of the session. But one of the questions that I've received is what so you spoke about community health workers, and both you and Dr. Mahesh have worked at the community field level. And so, how can we use some of these tracking tools that we are developing, say, for example, at RAIN Foundation, and how do those help at the community level? What do you see from that perspective?
The community health workers, as I told you, that they are closer to the people. They live in the same village, and if they are empowered with the technology, they can very well contact the doctor or whosoever is available there, and the services can be provided in time.
Yeah.
So that is what can be done with community health workers.
Fantastic. And I think some of these tracking tools would help them track and keep that updated on an ongoing basis instead of working on paper-based tools, stuff like that, right?
Yeah.
Dr. Mahesh, would you like to add something there?
No, I fully agree with that. Tracking is going to be very, very helpful. So I think we need to work on that.
Excellent, excellent. All right. So as I said, I think this was a very good comprehensive overview of the challenges that we face globally in India, and then within India, the discrepancies that we see with the rural and urban divide, and some of the things that we are trying to do at RAIN Foundation to bridge that gap. I thank everyone for joining today's session, and I request everyone to visit the RAIN website if they want to ask and questions as we go forward. Thanks a lot to all our experts, Dr. Anurag, Dr. Mahesh, Rakesh, and we will talk about these aspects maybe also in the future. Thank you, everyone.
Thank you.
Thank you.
Bye-bye.
Thank you.
Bye.
Thank you.